Hello, my name is Danielle Blanchard. I was born and raised in Kasilof, Alaska. I've worked with the Alaska Native Tribal Health Consortium since 2010 in various departments. Most recently, I have worked with organizational development. And today, I'm going to talk to you about who we are, where we've been, and where we're going. My intent in this conversation with you is to give you an idea of not only who ANTHC is, but also how we intend to go towards our vision and our future goals. Unlike most organizations, ANTHC leads with its vision statement that Alaska Natives are the healthiest people in the world. To support that vision, our mission statement and our values help give us some guiding behavioral practices. ANTHC values are very important, and I encourage each member of our employment to take a look at these values and memorize them, and also to think about them as you continue to listen to this presentation. The values of achieving excellence, Native self-determination, treating with respect and integrity, health and wellness, and compassion come into play with our everyday lives at ANTHC. ANTHC's key customer group are the Alaska Natives of the state of Alaska. There are roughly 150,000 Alaska Natives, and they comprise about 229 tribes. These tribes are organized into roughly 39 tribal health organizations. ANTHC as a corporation is comprised of 4 main divisions. The first division, the Alaska Native Medical Center, is the hospital, as well as our outlying clinics. ANMC employs roughly 80% of our employees. DHE, or the Division of Environmental Health and Engineering, primarily works with our rural communities to provide safe water and sewer systems. DHE also does environmental monitoring. DCHS, or the Division of Community Health Services, helps create capacity within the Alaska Tribal Health System by providing programs such as our CHAP, our Community Health Aid Program. They also do programs such as epidemiology, tobacco cessation, and cancer screenings. The last division is CBSS, or the Consortium Business Support Services. This division houses departments such as finance, human resources, and organizational development. ANTHC likes to say that we have a vision that goes back about 40 years. Though there's a good argument to say that this vision really goes back further than that. We track our history starting in the year 1953. In 1953, the Indian Health Services operated the original Native Hospital down on 3rd Avenue in Anchorage. We still have a lot of employees within ANTHC who were born in that hospital. At that time, the federal government had complete management over all Indian health programs. In 1969, the Alaska Native Health Board was created. This board was created as an advisory board for the Indian Health Services to advise the IHS on specifically Alaska Native challenges. In 1975, Congress passed the Indian Self-Determination and Education Assistance Act. This opened the gateway to allow for tribally management health programs throughout the state. If we fast forward a little bit into the 90s, you start to see some planning going on for the idea of ANTHC and their ability to take over from the Indian Health Services the tribal programs. In 1997, ANMC, as it exists today, was opened here on Tudor. At the time, it was about a 150-bed hospital. It's grown since then. In the late 90s, we start to see more momentum towards ANTHC as it exists today. In 97, in September, Congress passes an act that actually creates the structure for which ANTHC will follow. In December of that same year, ANTHC is officially incorporated as a 501c3 nonprofit and as a tribal entity. In January of '98, ANTHC appoints its first board members. We still have 4 of those original board members on our board today, which has allowed for a lot of continuity in our programs and our management. In September of '98, ANTHC files a formal proposal to take over management of the health programs from the Indian Health Services. And in January of 1999, ANTHC completes that transfer and raises the flag. We become the largest tribal self-governance organization in the United States. This is a distinction we still hold today. There's been some changes in that last 15 years or so. To start off with, we've had a little bit of a population boom. We've done some great work through our DHEAT department, increasing the number of communities that have water and sewer services. And we've had some huge increases in our employment. In 1988-89, we employed about 180 staff. This was basically the hospital staff, and these were all IHS individuals. In 2013-14, we had around 2,500 direct hire staff members. We can also include a further 2,000 staff members that we refer to as non-employees. These are our contractors and students. We've had a higher level of admittance in the past years, as well as a little bit of a baby boom to support that general population boom. And finally, the numbers at the bottom are very important for how we run today. Not only has our revenue and expenditures increased, but there's been an increase in the amount of revenue versus expenditure as well. This has allowed for a very financially solvent organization to happen. It takes about $1 million a day to run ANTHC. At current time, we have roughly 110 days of cash on hand. What this means is that if there were no funding coming in whatsoever and all funding had been cut, ANTHC would still be able to function in its current capacity for 110 days. This should give some financial security to not only our employees, but our patients as well. One of the other big changes that happened in our revenue between 98-99 and 2013-14 is that in the late 90s, ANTHC was almost 100% funded by the federal government through the Indian Health Services. Today, that funding comprises about 40% of our funding. The other 60% is made up of grants as well as third-party payers. Tribal ownership is one of the key values within ANTHC, that value of native self-determination. This allows for ANTHC to do local decision-making. Instead of health programs being directed from Maryland, the IHS headquarters, or even Portland, the West Coast headquarters, this allows for Alaskan tribal members to direct where these programs are and how they face the challenges that are unique to the state. This has also allowed for different resources of funding to be available, flexibility in our access to grants as well as tribal status protections has allowed for access to other funding either statewide or in the federal government. ANTHC is a member of what's referred to as the Alaska Tribal Health System. This is a system that employs roughly 6,000 Alaskans throughout the state. The health system is made up of the 150,000 Alaska Natives and is a voluntary affiliation of the 39 Alaskan tribal organizations. Each of these 39 different tribal or health organizations serves a specific geographic region in the state. As you can see, these regions vary not only their size, but also their population base. So what makes this a system? In 2004, a Memorandum of Understanding was created that linked the 39 tribal health organizations into the Alaska Tribal Health System. They share the advocacy of the Alaska Native Health Board, that health board that was originally created in 1969 to advise the Indian Health Services, still exists today. They also have the ability to create what's referred to as the statewide legislative priority list. Instead of each of these regions competing amongst each other for state funding, they come together and they agree on a priority list for the challenges facing their populations today. This is referred to as the Alaska Native Health Plan. This same ability to come to an agreement and a priority list is utilized in negotiations with the Indian Health Services. On an annual basis, the 39 tribal groups come together to negotiate with the Indian Health Services what is referred to as the Alaska Tribal Health Compact. This is the agreement between the Indian Health Services and the Alaska Tribal Health System on what funding should be put forward towards what programs. That was an explanation of what the system is comprised of and how it was built. But what that really means for our patients and our people is that it provides several levels of care. It provides care at the appropriate time, at the appropriate place, and at the appropriate level. What you see here is what we refer to as the continuum of care, or the circle of care. It starts with our smaller communities, which often have what's considered a village primary clinic. The village primary clinic is often staffed by one of our CHAP members, our community health aides. These community health aides come in a range of levels depending upon their education, the range being a 1 through a 4. A very small village, for instance, may have a level 1. This individual could render basic aid, suturing or helping with sprains, things like that. If your care needs were more intense than that, you would most likely be sent into a sub-regional mid-level primary care. This is a clinic that would most likely be staffed by a mid-level provider, such as an advanced nurse practitioner, as well as probably a CHAP, and possibly a registered nurse. If your care level was higher than that and you needed to see an actual physician, you would most likely be sent into a regional hospital. There are 6 regional hospitals throughout the state of Alaska, and they are staffed with our providers levels through a registered nurse, advanced nurse practitioner, up to a physician. If, however, you needed something more specialized than what could be provided in a basic hospital setting, for example, orthopedic surgery or neurosurgery, then you would be sent into Anchorage and you would be seen at the Alaska Native Medical Center. ANMC is considered the tertiary care level for the state of Alaska. We house not only our normal nurses and doctors, but we also have a number of specialty clinics. However, there are some things that even we can't do. For example, ANMC does not have a burn unit, nor do we have the capacity to do open heart surgery at this time. If those were the case, or you needed something more specialized than that, you would most likely be referred out to another area, either in town, say Providence or regional, or most likely to the lower 48 down to Seattle or one of the specialties there. The state of Alaska is very large, as many people know. And this provides us with one of the biggest challenges to care that our people face. The term access to care means something a little different in the lower 48 than it does up here. Access to care in the lower 48 often refers to the ability or availability of appointments. Here, it actually refers to the availability or ability to get to your appointment. Take, for example, the fact that Ketchikan sits down here at Charleston, South Carolina. Anchorage is located roughly around Joplin, Missouri, 3 states away. Take a minute and picture yourself as a patient. You are in need of medical care that is fairly severe and cannot be provided in your local area. This most likely means you're either fairly injured or you are dealing with a chronic issue that needs some specialized care. Most likely you are not feeling well. You might even be very scared about what your future holds for you. Now picture for a moment that you come from Charleston, South Carolina, and you're not the most economically well off necessarily. In order to receive your care, you have to travel 3 states over. You may have never been to Joplin, Missouri. You may have never seen what the city looks like or know how to get around it. You may only be able to travel with just yourself because of your economic circumstances, and you're not really sure where you're even going to stay once you get into Joplin. This is a very real circumstance for a lot of our patients. You will notice I didn't even pick the most strenuous journey that could potentially be made here. You can add on top of this the idea that not only would you have to travel this great distance, but it's very possible in the state of Alaska you would be taking multiple modes of transportation. anything from a snow machine to a boat to a four-wheeler. In some cases, dog sled is not out of the picture. This is where the ANTHC value of compassion and treating with respect and integrity comes into play. This is what our patients face on a daily basis. And it is our job to make that access to care piece a better solution. So the challenges. We've mentioned the access to health care, but there's some other challenges as well. The status of health. The Alaska Native population faces different health status challenges than most of the U.S. population. For example, this list here is the leading causes of death for the Alaskan Native people. You will notice that it looks slightly different than the U.S. population. The leading cause of death among the U.S. population is heart disease. For the Alaskan Native peoples, it's cancer. So our vision. Our vision is that Alaska Natives are the healthiest people in the world. This is a very ambitious vision. This is a vision that we want to take the 150,000 Alaska Natives in this state, and out of the billions of people on this planet, make them the healthiest individuals out there.